Welcome to Big Data and Your Health Record. I'm Dr. Michael Warner with Patient Advocacy Initiatives. Before we get started, please answer 3 quick questions. Decades ago, lawmakers and health policy experts knew that technology would someday reach the healthcare sector of our economy. Look how technology has advanced production and manufacturing. We can also see examples of advancements due to technology in transportation, the media, and entertainment. Technology promises to advance the healthcare system as well. Health policy leaders are confident that big data analysis of patient information will help us improve healthcare quality, cost, and satisfaction. In order to apply information technology to healthcare, we first needed to transition health records from paper to digital format. To promote the transition from paper medical records to electronic health records, EHRs, our government issued $30 billion in meaningful use incentives as part of a 2008 stimulus package. This means that doctors and health systems were given financial bonus payments for going digital, and it worked. In 2008, only 17% of physicians used electronic health systems, but by 2012, it quickly rose to 78%. By 2015, the government started penalizing doctors with lower payments if they did not use certified electronic health record technology. Meaningful use also required proof that a certain percentage of patients would interact with the patient portal. To achieve meaningful use too, the portal only needed to reveal selected parts of the record to the patient. It did not include parts of the history, such as history of present illness, review of systems. Not surprisingly, only a small percentage of our population has read their full health record. The Medicare Access and Chip Reauthorization Act of 2015, MACRA, calls for patients to access and read their health record. In order to coordinate care through patient engagement, patients are also asked to contribute information to the health record as patient-generated health data. The MACRA May 9, 2016 proposed rule calls for tracking of this measure starting January 1st, 2017. The government is counting on big data to help us solve our healthcare problems of quality, cost, and satisfaction. We are not ready for big data in healthcare because we have 2 major problems. The first is the way we track disease, and the second is with the accuracy of information. Number 1, claims data corruption. Our government looks to billing and coding claims to monitor what is happening in healthcare. Because claims data is sent to the government, particularly Medicare and Medicaid, and sent to third parties, such as health insurance companies, it will be the first to be applied to big data. Claims data is the information that is generated when a medical service, procedure, or treatment is given to you. You can think of it as a cash register receipt. Imagine if a patient sees you, the doctor, for diabetes, hypertension, hypothyroidism, and a lump in the right breast. Box 21 on the 1500 health insurance claim form, formerly known as the HCFA 1500 form, is where the diagnosis codes are entered. If you use an electronic health record system, then the diagnoses that you enter in the medical decision-making process automatically populate field 21 of the 1500 health insurance claim form. I contest that some of our claim-based information today, and nearly all of it prior to 2014, are misleading, inaccurate, and therefore corrupt. Because, though the paper version of the 1500 allows for 12 diagnoses, processing the claim through clearinghouse vendors narrows it down to only the top 4. When someone talks about claims data, they are often only skimming information off the top. Here's an example. Let's say we are working together in a medical office and we are seeing someone for the chronic care of diabetes. The ICD-10 code is E11.8, type 2 diabetes mellitus without complications. All right. Hypertension, I-10, essential hypertension. Hypothyroidism, E03.9, hypothyroidism unspecified, plus a new problem, lump in the breast, N63. Okay, so you have 4 diagnoses. Let's also say that during the visit, the patient complains of pain when urinating. and we obtain a urinalysis. In order to properly enter the painful urination code R30.9 and justify the urinalysis as being medically necessary, this code must be one of the top 4. Now sure, we can put more than 4 diagnoses in the record, and more than 4 can be submitted as part of the billing claim. But even at the time of this recording, many clearinghouse vendors still only take the top 4. I practiced for over 20 years. Sadly, the claims data that tracked my practice and reported to the government and third parties only looked at the top 4 diagnoses. So here's the problem. Diabetes, hypertension, hypothyroidism, breast lump, painful urination. Which one do you leave off the list of top 4? Painful urination needs to be one of the top 4 because I need to justify the urinalysis. Do I leave off diabetes? If I do, then someone would say, hey, what's the matter with you? You cared for this person with diabetes, you ordered laboratory tests, you reordered medications. Yeah, when the person sees you in the office, you do not even acknowledge that they have diabetes. I think we need to create another button for you to click on the computer. The National Uniform Claim Committee, NUCC, which is an advisor to the Centers for Medicare and Medicaid Services, CMS, recognized this problem and gave a recommendation in April 2014 that the number of diagnoses should be expanded from 4 to 8. Why just 8? But at least it's more than 4. However, because the NUCC is not a regulatory agency, many vendors have continued to process medical claims with a limit of 4. Less than a year ago, when I left the practice of medicine to do this project, I was still limited to only 4 diagnoses. Can you imagine working in any industry where you can only count to 4? This means that much of our current data and nearly all of our data prior to 2014 is corrupt. Claims-based data tells us whether someone had urinary burning when they saw the doctor, but missed out on the patient's story. The big picture is to know you are about to be misrepresented by the data. You will be accused of doing less when in fact you did more. Number 2, patient health record data inaccuracies. The second problem is inaccuracies within the individual health record of the patient. Big data and small data will demand more patient information that will include the history. Doctors do not have the time to obtain detailed histories and document each answer, but patients do. I'm going to show you how to outsource the history to the patient, who, by the way, wants to tell his or her story. If the patient is unable to help assemble the history, then a family member, a friend, or a caretaker can assist. It's time for doctors to work at the top of their licensure. The electronic record is not here to replace doctors. It's here to empower them. We need to use EHR systems as a tool. Currently, it's using doctors as a tool. We have an opportunity to enroll our patients in partnerships in healthcare. They are eager and willing to prepare their histories in preparation for the visit. In return, we will populate the patient health records with rich details, which will be to the advantage of data analysis. We're going to show you how to do this with a process that lessens your work and empowers patients to tell their story. Let's talk about the law and how we are supposed to accommodate a patient's right to request and amend the health record. Thank you for participating in this module. Please answer these quick questions, and I'll see you at the next one.